I'll be talking about testicular regression syndrome, vanishing testes. It is a report of two cases. Synonyms and some terminologies. Testicular regression syndrome, TRS, it is used in the pathology literature. Vanishing testis syndrome, it is used in the urology literature. Congenital anorchia, anorchism, it is a complete absence of both testes. It is very rare, 1 to 20,000 male. Congenital monoorchidism, absence of one testis, which may be due to either a non-palpable abdominal testicle or an atrophic testicle. Acquired anorchia, it may be due to surgical removal of both testes, such as in the cases of prostatic cancer, devascularization during herniatomy or orchidopexy, severe trauma. Definition and general background. Testicular regression syndrome is a condition which is considered to be due to the subsequent atrophy and disappearance in fetal life of an initially normal testis. Anatomically, it is characterized by rudimentary spermatic cord and epididymis with absence of macroscopically identifiable testicular tissue. A vanishing or regressed testis affects approximately 5% of patients with cryptorchidism, which is about 3% of full-term neonates and about 1% by the age of 1 year. TRS may be sporadic in vast majority, that is, the patients are otherwise normal with no significant family history. TRS may be associated with other defects, including severe mental retardation in chromosomally normal siblings or occurring in several members of the same family. This disorder may be unilateral or less commonly bilateral with partial or complete absence of testicular tissue. Etiology. The exact etiology is unknown. Testicular regression syndrome is thought to be the result of antenatal or perinatal vascular thrombosis, torsion, or endocrinopathy. Recent studies strongly support antenatal or perinatal torsion theory, vascular accident of a mal-descended testis rather than an endocrinopathy. In addition to the young age of the patients, the histological findings of dystrophic calcification, hemosiderin deposition along with the hemosiderin-laden macrophages, that is siderophages, absence of viable testicular tissue, presence of relatively normal spermatic cord elements, supported the hypothesis of remote infarction, leading to unilateral or occasionally bilateral anorchia. The presence of spermatic cord structures is evidence of the presence of the testis in the early intrauterine life. Genetic studies. Testicular regression syndrome has been observed in association with genetic abnormality, such as microdeletion of the Y chromosome and boys with persistent of Mullerian duct structures. All chromosomes, including the Y chromosome, are divided into a short arm and a long arm. Most deletions causing azoospermia or oligozoospermia occur in regions of the long arm known as the azoospermia factor regions, AZF. The AZF regions are further divided into AZF-A, proximal region, deletion of which is associated with azoospermia and germ cell aplasia. AZF-B, central region, deletion of which is associated with azoospermia and germ cell aplasia. AZF-C, distal region, deletion of which is associated with oligozoospermia and areas of sperm production can still be found with a testicular biopsy. Y chromosome microdeletion testing is run in cases of azoospermia or oligozoospermia. Persistent Mullerian duct syndrome. It is a disorder of sexual development that affects male. It is a rare form of male pseudohermaphroditism caused by defects in synthesis or actions of Mullerian inhibiting factor. It is produced by the Sertoli cells in male fetuses and signals the regression of the Mullerian ducts, that is, fallopian tubes and uterus. PMDS is caused by mutations in the AMH gene in type 1 or AMHR2 gene in type 2 PMDS. It is inherited in an autosomal recessive manner. PMDS is characterized by the persistence of Mullerian duct structures in a normal karyotype male, 46XY. Males with PMDS have normal male reproductive organs, normal male external genitalia, female reproductive organs, that is, a uterus and fallopian tubes, and descended testes, cryptorchidism, or inguinal hernias. These may be early signs of PMDS, persistent Mullerian duct syndrome. Types of persistent Mullerian duct syndrome. There are three types. Type 1, male type. Its incidence is 60 to 80%. The testis present in the scrotum or in the inguinal canal and can be brought into it by gentle traction. Type B, type 2, it is also male type. Its incidence is 20 to 30%. It presents as transverse testicular ectopia. The third type is a female type. Its incidence is 10 to 20. It shows bilateral cryptorchidism. This is present at ovarian position with respect to the uterus, which is fixed in the pelvis. This photo shows hernia uteri inguinal with transverse testicular ectopia. The uterus and both the testes are coming out of the abdominal cavity through left inguinal ring, and the testes are located at a site analogous to ovaries. Fallopian tube, uterus, right and left testes at the sites of the ovaries. Clinical presentation. The clinical manifestations of testicular regression can be classified into prenatal non-acute event, postnatal acute event. It is also called an early neonatal event. The prenatal non-acute event is subclassified into early prenatal event. It is an embryonic event, late prenatal event, fetal event. Early prenatal event. In early prenatal event, the neonate presents with a firm small testicle or even with an absent pea-sized and or napping testicle. Vanishing testis syndrome. Late prenatal event, it is fetal event. It occurs close to or during the time of delivery. The testicle is enlarged and firm and can be tender or non-tender with a typically discolored hemiscrotum. Postnatal acute event, early neonatal event. Postnatal testicular torsion can occur after birth within the first 30 days of life. Postnatal torsion presents with acute tenderness, swelling, and overlying scrotal skin changes in a testicle. Early loss of both testes in the antenatal period can result in genital ambiguity. The patient phenotype probably depends on the extent and timing of the intrauterine accident in relation to sexual development. TRS patients usually exhibit a normal male 46XY with unilateral congenital monoorchidism or bilateral congenital anorchia non-palpable testis. However, although uncommon, the phenotypic spectrum may be a phenotypic male with micropenis, inconspicuous penis, or severe intersex features. 2. Phenotypic female. What is the micropenis? Micropenis, it is also called microphallus, refers to an abnormally small but normally structured penis. The condition is caused by hormonal or genetic abnormalities. The most common is hypogonadotropic hypogonadism. A micropenis may be associated with testicular regression syndrome, minimal scrotal development, and unilateral or bilateral cryptorchidism. A micropenis has a stretched penile length SPL of less than 2.5 standard deviation below the mean for the male's age. SPL is measured from the pubis to the tip of the stretched penis. There is no cure for micropenis, but hormone therapy and phalloplasty may be done. This photo shows a testicular remnants located by the scrotal exploration. Atrophic testicular tissue described as dense matrix of fibrous connective tissue. Testicular napping is the residual tissue of the human testis. It is associated with a relatively normal vas difference. Microscopic description. Regressed or vanishing testis is indicated by microscopic features of remote infarction including fibrosis and fibrovascular nodules, hemosiderin along with hemosiderin-laden macrophages, that is siderophages, dystrophic calcification, presence of relatively normal spermatic cord elements, Leydig cells near epididymis or proximal vas difference. Residual testicular tubules are found in less than 10% of cases. Seminiferous tubules with viable germ cells in the testicular remnant tissue have occasionally been reported. Case number 1. Clinical history. A newborn boy had an enlarged, hardened, and non-tender right testicle along with discolored scrotum. It was discovered at delivery initial neonatal examination. Ultrasound with Doppler color flow showed absent blood flow to the affected right testicle. Right orchiectomy and contralateral orchiopexy were done 4 hours after the birth. Gross description: an orchiectomy specimen measures 2.3 by 1.5 centimeter with firm grayish cut section. Microscopic feature: this photo shows testicular infarction involving the lobules, seminiferous tubules, and the interstitium with recent hemorrhage. These photos show dense neutrophilic infiltration attacking the necrotic lobules, seminiferous tubules, and interstitial cells of Leydig. Dense neutrophilic infiltration attacking necrotic lobules, seminiferous tubules, and interstitial cells of Leydig. Dystrophic calcification of necrotic seminiferous tubules. These photos show fibrosis with the chronic inflammatory cells surrounding the necrotic seminiferous tubules. In addition to dense neutrophilic infiltration, hemosiderin deposition, brown pigment, along with hemosiderin-laden macrophages are seen in these photos. Lobular fibrosis, along with dystrophic calcification, chronic and acute inflammatory cell infiltration, and widening in spaces in between the seminiferous tubules. Dystrophic calcification of the necrotic seminiferous tubule, mainly along the basement membrane, interstitial cells of Leydig. In addition to dystrophic calcification of the seminiferous tubules along the basement membranes, we can see ruptured seminiferous tubules, indicating necrotic basement membrane. Here we can see thickened blood vessels with many migrating neutrophils. Tunica vaginalis with underlying dilated congested blood vessels, fibrous nodules, recent hemorrhage can be seen. Relatively normal vas difference and epididymis along with hemorrhage and congested blood vessels also have been seen. What is the diagnosis? The diagnosis is testicular regression syndrome, late prenatal event, fetal event. I cannot say vanishing because the testis is not missing. Case 2, number 2. Clinical history. A 1-year-old boy was diagnosed clinically with left and descended testis since birth. On physical examination, there was a firm nodular area near the external inguinal opening. Excisional biopsy of a suspected area was done with a part of the adjacent spermatic cord. Gross examination, it showed a 2.5 centimeter cord-like piece of gray tissue. Microscopic description, this photo shows a complete absence of testicular tissue, vanishing testis. It is a missing testis. It has been replaced by a fibrotic tissue along with hemosiderin deposition and dystrophic calcification, dilated blood vessels, and lymphatics indicating old infarction. Relative normal spermatic cord and vas deferens duct. Absent acute inflammatory cell infiltration indicating resolution of acute inflammation. This image shows a relatively normal appearing vas deferens along with dilated congested blood vessels. This photo shows a complete absence of testicular tissue. It shows replacement by fibrosis along with hemosiderin deposition, brown pigments, hemosiderin-laden macrophages, dystrophic calcification, and dilated blood vessels. Ghosts of fibrosed seminiferous tubules are also present. This image, this is a high power of the previous image. It shows a total absence of testicular tissue. It shows fibrosis, hemosiderin deposition, this brown pigment, dystrophic calcification, and dilated blood vessels. Ghosts of fibrosed seminiferous tubules are also present, reminiscent of tubular remnants. What is the diagnosis? Testicular regression syndrome, vanishing testis, early prenatal event, embryonic event. I can say vanishing because the testis is missing. Prognosis and treatment. Primary testicular failure, primary exocrine testicular failure, it leads to male infertility due to spermatogenic failure. Primary endocrine testicular failure, which is caused by a deficiency or absence of Leydig cell function, testosterone deficiency, hypoandrogenism. Although the precise fate of these remnants is uncertain, the presence of germ cells at least indicates a potential for germ cell-derived neoplasia. So there is a theoretical risk of malignant degeneration. Excision of testicular remnants is recommended. Treatment of persistent Mullerian duct syndrome may involve surgery to place testes within the scrotum and to remove Mullerian structures. Summary. Testicular regression syndrome is a condition which is considered to be due to the subsequent atrophy and disappearance in fetal life of an initially normal testis. A vanishing or regressed testis affects approximately 5% of patients with cryptorchidism. TRS may be sporadic in vast majority or associated with other defects such as Y chromosome microdeletion. This disorder may be unilateral or less commonly bilateral with partial or complete absence of testicular tissue. The exact etiology is unknown. The clinical manifestation of testicular regression can be classified into prenatal non-acute event and postnatal acute event, early neonatal events. Prenatal non-acute event is subclassified into early prenatal event, embryonic event, and late prenatal event, fetal events. TRS patients usually exhibit a normal male. However, the phenotypic spectrum may be a male with micropenis or severe intersex features to a phenotypic female. The patient would suffer from male infertility, primary exocrine testicular failure, spermatogenic failure, and hypoandrogenism, primary endocrine testicular failure due to a deficiency or absence of Leydig cell function. There is a theoretical risk of malignant degeneration of the testicular remnants. Excision of the testicular remnants is recommended. These are the references. Thank you. Thank you.